Okay, I am back. Let us continue. Raise your hand if you're able to hear me clearly. All right, that's good enough. That's good enough. All right, so we just completed the first section of the patient assessment, which is the scene size up phase, which incorporates ensuring that your scene is safe, taking appropriate standard precautions for yourself, crew members, identifying the mechanism of injury, which is specific to your trauma patients, nature of illness, which is specific to medical, the number of patients, determining the number of patients, and whether or not you need additional resources. The next section of the patient assessment is the primary assessment. Extremely important, and it is the area of the assessment that EMTs have a lot of trouble with. It is the area of the assessment that students struggle with. And it is also the area of the assessment where I observe that a lot of the persons who come into the course with a medical background also struggle because you're accustomed to doing things a particular way. The pre-hospital assessment approach mirrors closely the approach that an ER physician consultant would use to assess a patient. That's what it mirrors. And notice I said ER physician. I didn't say a general practitioner or a doctor, a regular doctor. An ER physician consultant uses this approach. In the hospital setting, you will tend to see the approach where a device is placed on the patient's arm and a button is pressed to get readings and a history is obtained. That's what you will see more in the hospital setting. When an ER physician consultant, one that has proper training, assess a patient, they're going to use a ABCDE approach: airway, breathing, circulation, disability, exposure. That's your approach. In EMS, EMTs use the LOC, airway, breathing, and circulation approach. Every patient gets that assessment. Every patient. So the primary assessment begins when you greet your patient. You must understand the goal of your primary assessment. The goal is to identify and initiate treatment of immediate or potential life threats. That is the goal. We need to find things that can or have the potential to kill the patient and fix these problems quickly. It is not to put on a BP cuff or a pulse ox and press a button and ask questions about history and waste time. It is to identify things that are going to kill the patient quickly or has the potential to kill the patient quickly and address these issues. And there are three things that you must assess for that can kill a patient very quickly in the field: an airway that's closed, a chest that's not moving, and a patient that is bleeding excessively. Right? So if the airway is compromised, that can kill a patient very quickly. If their chest is not moving, that means they're not ventilating properly. That can kill a patient very fast. They're bleeding excessively and you don't control that, they're gonna bleed their entire blood volume out. That can kill the patient very quickly. So physically, you will examine the patient and assess the level of consciousness, airway, breathing, and circulation. Now, just like the scene size up, there are things that must be considered and there are things that must be done. So your primary assessment entails you will form a general impression of the patient and the environment. That's the first thing. You form a general impression of the patient and the environment. Then you obtain the patient's level of consciousness, assess and manage their airway, assess and manage breathing, assess and manage circulation. So the whole purpose of the general impression is to answer two questions. So when we form a general impression, we want to answer two questions. Does this patient look sick or injured? So you need to ask yourself that question. Does this patient look sick or injured to me? If the answer is yes to that question, then the next question is, how sick or injured is this patient? So that's the purpose of your general impression. So it's a visual assessment. And there are things that you will note. So when you form a general impression, you're considering the age, the sex, the race, the level of distress, and the overall appearance of the patient. And age, at this point, we're not trying to obtain the exact age because it's a general impression. We're trying to categorize the patient into an age group. So when I look at a patient, what I want to determine is this an adult? Is it a pediatric patient or is it a geriatric? If it's an adult, I am expecting typical presentation. If it's a pediatric, then my concern is going to be airway, airway, airway. If it's a geriatric, I am expecting atypical presentations. So note the patient's position, avoid standing over the patient, address the patient by name, introduce yourself, ask about the chief complaint, and address life threats immediately. So when you form a general impression, if you see something that is going to need immediate attention, when you make contact with the patient, you need to address it right away. Oops. All right, so the goal is to determine if your patient is stable. If the patient is stable, but there is a potential for that patient to become unstable or the patient is unstable. Now, after we have formed a general impression of the patient, so you look at the patient, age, race, level of distress, overall appearance, position, whether or not you see any life threats present that needs immediate attention. Then you look at the environment that you find the patient in. Are there any clues present in this environment that could tell me what exactly occurred or give me a hint in terms of what occurred? Then you make contact with the patient and you ascertain the patient's level of consciousness. So you start with the brain. The level of consciousness can tell you a great deal about the patient's neurologic and physiologic status. So the categories. Now you're seeing 3 categories here. Yesterday I gave you 6. Remember the 6 categories that your patient can fall in. It's going to become extremely important down the line. It will form the basis of your career as a EMS responder. So So your patient can be unconscious, the patient can be conscious with an altered level of consciousness, so they are disoriented. Or the patient can be conscious with an unaltered level of consciousness, meaning they are fully oriented to person, place, time, and event. Assessment of an unconscious patient will focus on airway, breathing, and circulation. Sustained unconsciousness should warn you of a critical respiratory, circulatory, or central nervous system problem. Conscious with an altered level of consciousness may be due to inadequate perfusion. Perfusion is the circulation of blood within organ or tissue. Now, outside of issues with perfusion, a patient's level of consciousness can be altered by medications, it can be altered by drugs, can be altered by alcohol poisoning, can be altered from infections, it can be altered because the blood sugar is too low, can be altered because the patient is too dehydrated. There are a lot of things that can cause a patient's level of consciousness to become altered. To assess the responsiveness, you will use the mnemonic AVPU, which at this point in the course, all of you are very familiar with. So, is your patient awake and alert? And if you're checking to see if your patient is awake and alert, then you need to check for orientation to person, place, time, and event. V is the patient responding to verbal stimuli. P is the patient responding to pain. U is the patient unresponsive. If you get to the point that your patient is unresponsive, then you need to be thinking about airway. Is the airway compromised by the tongue? Is the airway compromised by anything else? Now, points for checking for pain. So we have been talking about pain, but we have not put a lot of emphasis on where we would check for pain. So these are your points that you can consider. Pinching the earlobe, that will not be a go-to for me because I don't think it's painful. You can put pressure on the supraorbital nerve, that's the one in the middle. So this one can put pressure on the supraorbital nerve. That is a go-to for me because a lot of pressure is not required to get a response. However, your thumb placement is important. So that's a go-to for me. You can pinch the neck. Again, that will not be something that I initially go for because it depends on how much pressure you can apply to the area to get the response that you want. Also, you can use a pen or pencil and put pressure on the cuticle of the nail bed. Go ahead, Mr. Jones.
Something just came to me with this AVPU.
Yes.
The scenarios that you previously gave us, it was a case where either the patient was unresponsive or the person responded to painful stimuli. But my question is, if we are checking below C and the person responds to verbal stimuli, do we still need to check for painful stimuli, or is that
No.
jumping ahead to something else?
If they're responding to verbal, you don't need to go to pain. Okay? So if they respond verbally, don't go to pain. But if they're only responding to verbal, then it would be good for you to evaluate the patient's orientation. So if they're not fully awake and alert and responding to verbal stimuli, ensure that you check orientation. So these are the points for pain, and I mentioned putting pressure on the cuticle or the nail bed. Back in the days, we used to use a sternum rub, right? A sternum rub by putting the knuckles in the center of the sternum and rubbing the area to elicit pain. It's not something that is practiced anymore in the pre-hospital setting. You will see persons still doing it in the hospital setting, but it's not a standard approach based on the current curriculum. And the reason for that is it's not appropriate for the female population, and you can elicit a response that bypasses the brain. So you can do a sternum rub and get a reflex, a spinal reflex response. And that's not the purpose of a painful stimuli. When we apply painful stimuli, we're trying to determine if signals are still going to the brain. So the sternum rub is not something that is taught anymore. No, and this is just a little outside of the course, but I will use a sternum rub, and I'm not telling you to go out there and do this. I will use a sternum rub if I think someone is pretending to be unresponsive. So that's when I'll use it. Because there are some patients that will pretend to be unresponsive. So I will use a sternum rub for those patients. But just understand that it's not traditionally taught anymore, and there's a reason for that. So for patients that you're suspecting spinal or head injury, if you do a sternum rub, you can get a reflex response. Keep that in mind. So assess the level of consciousness. Orientation. The orientation tests the patient's mental status. So you're evaluating the patient's ability to remember who they are, where they are, what time of day it is, which day it is, which year, and what exactly has occurred. If they are not able to answer these four questions clearly, then they are said to have an altered mental status. So that's what altered mental status means. It means this patient is not fully oriented to person, place, time, and event. Now, the orientation in the order that it is listed, person, place, time, and event, will evaluate long-term memory, intermediate memory, and short-term memory. Altered mental status is any deviation from alert and oriented to person, place, time, and event. Any deviation from the patient's normal baseline. Now, identify and treat life threats. So after you have ascertained the patient's level of consciousness, the next step is, are there life threats present? Is the airway compromised? Is the breathing compromised? Is circulation compromised? So conditions that can cause sudden death, airway obstruction, respiratory failure. Now, which bright spark can tell me what would identify respiratory failure in the field? So what am I looking for respiratory failure? We did airway management yesterday. Anybody can answer that question? Go ahead, Ms. Roxburgh. Go right ahead.
Okay, all right. Can you hear me?
Yes, I can.
Okay. So respiratory failure identified would be the person is the person's consciousness, level of consciousness is, you checked it and there is pretty much no consciousness from that person. There is no poor or no chest rise and fall.
Okay. All right. Yes. So the patient has a decreased level of consciousness and the chest rise is inadequate. Anybody else? I see Brooks and there was someone else, Miss Beckford. Are you going to say the same thing or you have something different?
You hear me, sir?
Yes, go ahead.
Respiratory failure that we talked about yesterday, sir. No carbon dioxide in the body, lack of oxygen.
Hold on,
So
Mr.
it
Brooks.
causes respiratory
Hold on,
failure.
hold on, hold on, hold on. Hold up a sec, Mr. Brooks. You're going to physiology and all of them stuff there. That's not what I'm asking. I'm asking if you have a patient in front of you. You have a patient in front of you, how are you going to know if this patient is in respiratory failure? That's really what I'm asking. Not asking about the physiology.
Whenever you aren't getting any breathing or any rise and fall of the chest, you know definitely that the lungs is collapsed.
Rise and fall of the chest being inadequate does not mean that the lungs has collapsed. So if the chest rise is not adequate, it means that your patient has a ventilation problem. If the chest rise is not adequate with altered level of consciousness, that is respiratory failure. We cannot know if this patient lungs is collapsing until we confirm it using a stethoscope. Yes, Mr. Doheny. And this is why I like when you participate, because it will tell me or show me where your understanding is and I am able to clear things up. So I encourage participation. You got that, Mr. Brooks? Good.
Positive, sir.
Mr. Doheny had your hand up. Go ahead.
Yeah, on site, what you can actually check for respiratory failure is check if you see any sign of hypoxia, like if the patient's skin appear black or bluish black, there's a sign that oxygen isn't circulating properly.
Checking for changes in skin color alone cannot identify failure. The key things that you need to pay attention to is the patient's level of consciousness as it declined, and is there adequate chest rise. These are the key things to identify failure. The skin color findings would come in your circulation assessment. It doesn't come in your breathing assessment, right? And yes, the skin can give you an indication of whether or not the patient is oxygenating properly or there is poor circulation. To know if a patient is in failure, you must look at the level of consciousness and whether or not the chest rise is visible. So that's respiratory failure. Yes, Mr. Barnes, go ahead.
What about the pulse too, sir? You don't check the pulse as to whether
We're talking,
it's your
we're
respiratory.
talking about a breathing assessment, not a
Okay,
circulation assessment.
okay, sir.
Good. So the pulse is going to tell you about circulation. That's what the pulse is going to tell you about. All right, now what would identify respiratory arrest in the field? So what am I looking for respiratory arrest? Go ahead, Ms. Roxburgh.
For respiratory arrest, the patient has completely stopped breathing. There is no chest rise and fall. There is no level of, or there is no consciousness basically as well. So they're completely stopped breathing.
That's half of the answer. So that answer is still incomplete. Go ahead, Mr. Scarlett. Respiratory arrest. What identifies respiratory arrest?
The person is unresponsive, no chest rise or no pulse.
If the patient is unresponsive, no chest rise and no pulse, that's cardiopulmonary arrest. That's not respiratory arrest. That's cardiopulmonary arrest. What identifies respiratory arrest in the field? Anybody else? Any takers? Quickly. Not a complicated question. Go ahead, Mrs. Morgan.
The patient is unresponsive and there's no visible chest rise.
That's a part of the
It is
answer.
not breathing.
That's a part of the answer. Mr. Fisher, go ahead. Come on, people.
Okay, I would add to what everybody else said in respect to unresponsiveness, no chest rise, but add that you open the airway and there's still no change.
No. Yes, Mr. Facey, go ahead quickly. And I think after this, we're moving on.
All right, cardiac arrest would be like patient stop
Hold on,
breathing,
man.
and within.
I didn't ask about cardiac arrest. Did not ask
Oh,
about
respiratory.
cardiac.
Sorry, respiratory arrest. Sorry, my bad.
Yes.
Is the cessation of breathing,
Right.
and if and within like a few minutes after, without any assistance, that patient could go into cardiac arrest.
No. Mr. Doheny, let me hear what you're saying.
All right, respiratory arrest is if this patient stop breathing or is ineffectively breathing.
Can't be ineffectively breathing. It must be stopped. Arrest means to stop. All right, so that's
Yeah, or
enough.
stop.
That's enough. A patient in respiratory arrest is a patient that's unresponsive with no chest rise and a pulse is present. That's it. As I say, it's not complicated. Conditions that cause sudden death: airway obstruction, respiratory failure, key findings, altered level of consciousness, poor chest rise. Respiratory arrest, key finding, unresponsive, no chest rise, but a pulse is still present. Once the pulse disappears, your patient is now in cardiopulmonary arrest. Shock, severe bleeding, primary cardiac arrest. All right. In most cases, begin with your airway followed by breathing and circulation, but you may switch that around. So there are circumstances in which you may switch it around and focus on CABCs, which situation in which you can switch around would be you identify excessive bleeding occurring. So you address the bleeding first, then you do ABCs. Or it's a patient that is in cardiac arrest. But I always teach students to simultaneously check for the pulse and the airway at the same time once the patient is not communicating. But your assessment becomes CAB for cardiac arrest, and it becomes CABCs if your patient is bleeding excessively. Now, after you have done your LOC assessment, the next step is to assess and manage your airway. So moving through the primary assessment, stay alert for signs of airway obstruction, ensure that the airway remains patent and adequate. Responsive patients, Patients who are talking or crying have an open airway. Watch and listen to how the patients speak. If you identify an airway problem, stop the assessment and work to clear the patient's airway. So, quick question, and we're not going to linger on this too long. If you have a patient that is responding to painful stimuli, so you apply painful stimuli and the patient groans, is that patient's airway patent? Go ahead, Mr. McCoy.
I would say no, not necessarily.
Why are you saying no? Why are you saying no,
You can
Mr.
always
McCoy?
grow without it.
All right, so my question to you, Mr. McCoy, if this patient's airway was closed, would you be able to hear a sound? That's the question. So if the patient's airway was closed, would you be able to hear a sound? You there, Mr. McCoy?
Yes, I'm hearing you,
So,
sir. You're not hearing me?
yes, so would you be able to hear a sound?
I was thinking
If
that
it's
you could
complete.
still hear some sort of sound.
Okay. Okay. So if a patient has a completely obstructed airway, you can't hear anything. So the fact that this patient groans when you apply pain, it means that the airway is patent. Now, if it's open or patent, if the patient groans for pain, is this airway adequate? That's my next question. So the patient responded to pain, that means there is an airway. Is it adequate? That's the next question. How are you going to know if it's adequate? You can't determine that. So, Miss Roxburgh, how did you come to the conclusion that it's not adequate? What have you done to determine that it's not adequate?
Okay, so I should have mentioned before. So I would have done the necessary. If he has had, depending on the position that I found him in, I would do the head tilt chin lift just to ensure that.
Right. So that's the point I'm moving towards. So if you hear sound, the patient groan, we know that an airway is present. The next step is to determine the adequacy of that airway by opening the airway with the most appropriate technique. Good. So that's the understanding I wanted to get to. All right. Things are going to get very technical from here going forward. Now, the unresponsive patients, immediately assess the airway. Use a jaw thrust technique when necessary, and we know when to use our jaw thrust technique. Use the head tilt chin lift technique when necessary. At this stage, we know when that is required. Relaxation of the tongue muscles is a cause of airway obstruction. If it is completely obstructed, are we going to hear any sounds? That's a question. So if the tongue is completely obstructing the airway, would I hear any sound? Go ahead, Mr. McCoy. I see you, Miss Barnes. Okay. If correct. If it is partially obstructing the airway, what type of sound are we gonna hear? So if the tongue is partially obstructing the airway, what type of sound? Snoring. Good. All right. So we're learning. Well, some of you learning. We will find out about the rest down the line. All right. So let's continue. Signs of obstruction in an unconscious patient: obvious trauma, blood or obstruction. They can present with noisy breathing, snoring, bubbling, and gurgling. What does bubbling and gurgling sounds indicate? Go ahead, Mr. Thomas. What does... Okay.
Sir, can you hear me?
Yes.
That means liquid is blocking the airway, sir.
Okay. Noted, noted, noted. Okay, so that would be an indication of fluid, whether that's vomitus or blood, maybe in the patient's ear passage. Crowing may indicate that some type of obstruction is present, especially if it's stridor, and you have other abnormal sounds like wheezing, rhonchi, reels. What does wheezing represent? Or what does that mean? You hear wheezing. Go ahead, Mr. Doheny. Wheezing.
It means that the bronchi is tightening,
The what
basically.
is tightening? I didn't hear the first part.
The bronchi.
The bronchioles.
Yeah, well, yeah,
The
thank you.
bronchioles,
Plural.
right? So the bronchioles
Tightening.
are constricting. So bronchoconstriction, that's lower airway constriction. All right. Now, if a patient is breathing extremely shallow or there is an absence of breathing, if they are breathing extremely shallow with a decreased level of consciousness, what is that referred to as? So they are breathing shallow with a decreased level of consciousness. What do we refer to that as? Go ahead, Miss Roxburgh.
Respiratory failure.
Good. If there is a decrease in consciousness, no chest rise, and there is a pulse, what is that referred to as? Go ahead, Mr. Ennis. Respiratory arrest. Why is there a question sign beside that, Miss Beckford? You're supposed to sure of yourself, right? Respiratory arrest. Good. All right, we're learning now. Now, after we have assessed the upper airway, the next step is to look at the lower airway, breathing. So we need to assess breathing. And when we assess breathing, we look at the rate, the rhythm, the quality, and the depth. So make sure the patient's airway is open. Make sure the patient's breathing is present and adequate. Ask yourself, is the patient breathing? Is the patient breathing adequately? Is the patient hypoxic? Consider providing positive pressure ventilation with an airway adjunct when the respiration exceeds 28 breaths per minute or respirations are fewer than 8 breaths. Now, for this particular slide, it is important for you to understand that you're not going to breathe for the patient based only on the numbers. So we don't use numbers alone to determine if we are going to breathe for a patient. You look at the patient's level of consciousness, you look at the rate, the rhythm, the quality, and the depth. So the patient must have poor chest rise or no chest rise with altered level of consciousness for you to decide if you're going to provide positive pressure with the use of an airway adjunct. You will not only rely on the numbers. So it's numbers tied to the patient presentation. Now, the goal for oxygenation for most patients is an oxygen saturation of approximately 94 to 99%. Observe how much effort is required for the patient to breathe. Are they presenting with retractions? Are the muscles being pulled in around the rib cage, in the chest, in the neck? Is there nasal flaring? Is there 2 to 3 word dyspnea or difficulty breathing, also known as staccato speech? Is there tripod positioning? Is there the patient in the sniffing position? Is the breathing labored? Respiratory distress, we went through all of this yesterday. You guys are expert now, so I don't need to go into details of what to look for. We looked at mild, moderate, and severe. What is important for you to remember is that if it's mild or moderate, your patient is still able to communicate with you and they still have visible chest rise. The patient must have visible chest rise for it to be referred to as distress. That is key. So once the patient has visible chest rise and there is difficulty breathing, it is distress. Severe distress, it becomes severe when the patient's level of consciousness starts to change, breathing rate starts to come down, breathing becomes more labored, but there is still visible chest rise. When they get to the point that they're in severe respiratory distress, this is where we need to prepare to breathe for the patient because they're about to fail. You see the exam question, the answer is to breathe for that patient. Respiratory failure, you guys are expert now at this. It occurs when the blood is inadequately oxygenated or ventilation is inadequate to meeting the oxygen demands of the body. The ultimate result of respiratory failure, the ultimate result is respiratory failure if not corrected. What key things we're looking for? Decreased level of consciousness, poor chest rise. And if respiratory failure is not corrected, then it will go to respiratory arrest, which is no chest rise with a pulse. If that's not corrected, it will go to cardiopulmonary arrest. No breathing, no pulse. Now, after the breathing assessment is completed, you will move into your circulation. So this is your breathing assessment. You're going to check the rate, the rhythm, the quality, and the depth. You count the chest rise for 30 seconds, multiply it by 2. If it's irregular, you do it for a full minute. The patient should not be talking to you at this point. For the rhythm, you're looking at consistency. Do you see a consistent pattern of chest rise? Is it regular or irregular? Quality, is there muscle use present? Is there abnormal lung sounds without auscultation or with auscultation? So at this point, we need to be listening to lung sounds. What is the pulse oximetry on room ear? Right? And is the patient in a specific position to breathe? Depth, can you see visible chest rise bilaterally? Once you have completed this assessment, you should know if you need to give your patient supplemental, high or low flow, or you need to provide positive pressure ventilation with high flow. Then we move into the next phase of our assessment. Assess circulation. And things that we will consider for circulation, again, we're thinking about the patient's mental status, thinking about pulse, skin condition, whether or not the patient is bleeding anywhere. That is a part of circulation. So assess the pulse. If the patient is communicating, you will assess the radial pulse or peripheral pulse. If the patient is not communicating, you will go for the carotid pulse or the pulse that is closer to the brain. So the pulse is a pressure wave that occurs as each heartbeat causes a surge in blood circulating through the arteries. Palpate, feel the pulse. If you cannot palpate a pulse in an unresponsive patient, begin CPR. Cardiopulmonary arrest is present. For the skin, we will look at the color of the skin. We're going to feel the temperature of the skin. In the pediatric population, we check cap refill. And so you're looking at skin color, temperature, hydration, cap refill. So evaluate the patient's skin color. We look at the palms of the hand for skin color. And if we see changes in the palms of the hand, then we look for these changes centrally. Can look around the lips, can look at the mucous membranes under the eyelids. A normally functioning circulatory system perfuses the skin with oxygenated blood. Determined by the blood circulating through the vessels and the amount and type of pigment present in the skin. Poor circulation will cause the skin to appear pale, white, ashen, or gray. When the blood is not properly saturated with oxygen, it will start to look blue or have a grayish color. Changes in skin color may result from chronic illness. So the patient can have cyanosis, they can have orange. What am I talking about? Orange, yellowish discoloration of the skin, which suggests that there might be an issue with their liver or kidneys. The skin can look excessively flushed and excessively hot. That's usually a sign of inflammation or infection developing. Now, for the skin temperature in our circulation assessment, we're not trying to get a thermometer reading. Right? We're trying to determine if the patient's skin feels warm and dry, cool and clammy, or excessively sweaty. So it's really to determine if the patient's skin is depicting any signs or symptoms of shock developing. And in this day and age, we would already have done a thermometer reading because that's what most protocols now require before we make contact. We check the temperature because of the whole COVID situation. But when we're doing temperature here, it's not to get an accurate temperature reading with a thermometer. It's to determine if the patient is showing signs of shock. The circulatory system is compromised. Abnormal skin temperatures are hot, cool, cold, and clammy. Now, skin moisture. Dry skin is normal. It shouldn't be excessively dry. Skin that is wet, moist, or excessively dry and hot suggests a problem. The capillary refill is evaluated to assess the ability of the circulatory system to restore blood to the capillary system. So you're basically squeezing the blood out of the capillaries from the nail bed, and it should turn pale. And when you release that pressure, within 2 seconds, it should turn back pink. So a normal capillary refill time is less than 2 seconds. If it's delayed, your patient may have a circulatory problem. It is an assessment that is more utilized in the pediatric population than the adult population. Now, bleeding assessment is a part of your circulation assessment, and it can come before you do the other checks in circulation, or it can come after. I prefer to do a bleeding evaluation early before doing anything else in circulation. So usually that's what I will start off with, especially for trauma patients. I'll look for bleeding first, and I'll check the pulse unless that patient is unresponsive, where the pulse would come first. So it's bleeding, specifically external bleeding we're looking for. If present, then we need to address it if it is significant. To assess and control external bleeding in trauma patients should occur before addressing airway or breathing concerns. So if you see signs of excessive blood loss occurring, that needs to be immediately addressed. Bleeding from a large vein is characterized by a steady flow of blood, and bleeding from an artery is characterized by a spurting flow of blood. So arterial bleeding mimics the contraction of the heart, so it is more difficult to control in the field. So controlling external bleeding can be simple. We apply direct pressure with dressing and secure the dressing in place with bandages. And we can also apply tourniquet based on protocols, your protocol allow. And we usually go for the tourniquet if the conventional methods do not work. And you need to have proper training before you can apply a tourniquet on a patient. All right, so let's break here. So we're at 10:36. Let me see. We will resume at 10:50. So we're gonna resume at 10:50. So let's take a little